cultural psychiatry turns a potential liability into a strength. You know, if you're a minority, you're different. But you know your minority group better than anybody else does. So therefore, if you become an expert in that minority group, then you're no longer a minority, you're an expert. My name is Russell Lim. I'm a health sciences clinical professor at UC Davis. I've been there since 1998, and one of the things I'm really proud of my work there is developing the Diversity Advisory Committee, where I've been the chair for the last 14 years. Well, if I were to define cultural competence, I would say that it's a way of working with patients to really kind of understand their experience. Many times when we train residents, we train them to fit people into particular categories. And cultural psychiatry is actually the opposite of that, where we try to see how they see themselves. And it's a different way of evaluating and talking to patients. So it's very exciting. Well, you know, I've had a long-standing interest in education. I think it started when I was in high school, and I tutored chemistry in high school. And I ended up doing that in college, and that was a lot of fun. So when it came to kind of deciding what I wanted to do with my life, I was saying, well, teaching could be good. So I went to teacher education school, and I learned how to do lesson plans, and that was challenging in its own way. I ultimately decided that I was going to combine my love for teaching with medicine. And I decided that I was going to, you know, somehow be a teacher in medicine. I didn't quite really know what that meant. And later on, as my residency proceeded, it kind of became clear to me. And so then I also think about how I became interested in cultural psychiatry. And I decided to apply to UCSF here in San Francisco. And I went for an interview, and they arranged for me an interview with the Asian focus unit that they had at San Francisco General Hospital. I really had this epiphany, this experience where I didn't feel like I was in a psychiatric ward. And I said, that's kind of strange. And so I said, I gotta know how this works. And you know, we took a tour. He explained to me that the patients ate rice with their meals, that they had hot tea. And then I started to notice little details, like there was a pull-down calendar, read day by day. I had one in my home with my parents, and so that was very familiar. There were also these calligraphy scrolls with, you know, red paper and black ink and in Chinese, and I was like, okay, that's familiar. And then there was, you know, there's a ping pong table in the rec room. There was fans on the walls, and then most of the staff are Asian, and they're bilingual, and so there was this just sense of, instead of being on a psychiatric ward, I was in someone's home, like my aunt or uncle's home, and I said, nah, I got to understand this better. And so the more I understood it, the more I wanted to teach it to other people, and I would say that's kind of where it all started. You wanted me to talk about how the Diversity Advisory Committee got started, and actually this is one of my favorite stories to tell. And one of the reasons for that is because I didn't plan it. You know, the best things in life are unplanned, and it's those magic moments where an opportunity arises, and then you step up and you say, okay, we should do something about this. So let me tell you how this started. We had a departmental retreat. It was about a year after I joined the faculty, and every department went up to the front of the room and they said, well, here's our 5-year plan. You know, we're going to do this, this, and this. And so the inpatient, outpatient, staff, consult liaison, etc. And I'm sitting there listening, and I'm slowly getting annoyed. And at lunchtime, I got together with people I knew from the department. I said, have you noticed that no one's mentioned anything about culture? And they kind of paused and they said, yeah, no one said anything about culture. And I said, you watch. The whole thing will end and no one will say anything about it. And I hope I'm wrong, but I think that's what's going to happen. So the day ended, and we were, you know, the last group gave their presentation. Moderator came up to the front of the microphone, and he said, well, you know, we've heard a lot of things today, and I wonder if there's anything that's been left unsaid. And I found myself raising my hand, and he called on me. And you know, I just tell you, I don't usually raise my hand a lot. And I said, you know, in a county where there are 7 threshold languages, I find it odd that we haven't mentioned anything about how to deal with these particular languages, and you know, and that none of the plans include anything about cultural competence. I think that's a real problem. And the vice chair came up, Dr. Bob Hales, and he said, well, Russell, why don't you put a small work group together and we'll see what we can do about it. And we did, and we've never stopped meeting. So what have we done? I think within the first few years of the committee, we were successful in adding a particular course to each year of the curriculum. So we now have a 4-year curriculum. One of the things I'm proud of is that we supported one of we had a chief resident who was very interested in religion and spirituality. So he developed a 4-year curriculum in religion and spirituality. So that got added to the curriculum. We had grand round speaker, 1 or 2 a year. Probably the thing I'm most proud of is our mentorship of residents. We have had 10 SAMHSA or CMHS fellows over the last 14 years. We've had 2 what we're now called APA Minority Diversity Fellows in the last 14 years, so that's 12. So we've been able to mentor our residents to become more involved in the APA, and most of them had a really good experience with it. Another one of the things I'm proud of for the Diversity Advisory Committee is that we've been able to shepherd this 4-year curriculum in culture and religion and spirituality. And how it came about that we won the award from ADPERT along with NYU, one of 2 programs in the country that were chosen as model curriculum, was that we found out that ADPERT was looking for model curriculum in various subject areas, and one of those subject areas was cultural psychiatry. So I said, okay. I collected everybody's syllabi, and put them together, and then I developed the rationale, which we were using, we just hadn't written it down yet. And then we also noticed that there were things that we actually weren't doing, so we added those. So for instance, the LGBT portion, I call it a work in progress. I think it's nice that we're recognized, but I mean, we're still, every year we tweak it, and you know, we try to make it so that the residents you know, find it useful, and that they learn something about cultural psychiatry. When I think about the future of education in cultural psychiatry, the first thing that comes to mind is the cultural formulation interview, which is just released in DSM-5. So we now have 16 questions where they can actually take the questions from the DSM-5 and use them. And there's also 12 supplementary modules. So that's going to be, I think, where we're going to be focusing a lot of our attention on how to teach that effectively. One idea for future projects in teaching about cultural psychiatry has been I wanted to develop standardized patients, so I could write cases, have actors portray the patients, and then have the residents try out the cultural assessment techniques on the standardized patients. And the teaching part would be is that the case is always going to be the same. What's going to be different is the resident trying the skills, and so we could actually develop, you know, evaluation system. Oh, did they use this question? Did they ask that question? And so that's a measurable way of helping residents learn the cultural psychiatry skills. Obviously, it requires some energy and preparation to do that, and we haven't had the resources to do that as of the moment. People have asked me how is cultural psychiatry relevant in the era when we're doing imaging, and there's a lot of emphasis on neuroscience and neurotransmitters, you know, and how is it important? I look at it as it's a way to have the appropriate diagnosis, a diagnosis that is culturally appropriate for the patient. So it might not be a DSM-5 diagnosis, but also we have to translate their symptoms into something that we can recognize and give it a DSM-5 diagnosis. So they actually get 2, one DSM-5 diagnosis and one culturally appropriate diagnosis. And then we can engage the patient in their treatment plan, and then they're much more likely to be adherent with the medications or psychotherapy that we prescribe because they feel understood by us. Second thing I would say about that is there is a psychologist named Joan Chow, and her specialty is the culture of neuroscience. So she combines her interest in psychology with her interest in imaging, And so she's trying to identify parts of the brain that have things to do with particular cultural measures that she's come up with. So I think that's kind of the frontier of cultural psychiatry, is matching up some cultural constructs with some actual brain imaging. Because really the problem is that in current psychiatric practice, we're into reductionism. That we have these lists and criteria that we're supposed to check off. And so it kind of simplifies things, but it also kind of shortchanges us, because we don't get into the richness of the person's experience and their worldview and how their beliefs about their illness, and especially what do they want? What are they afraid of? Those things are not on our checklist. So I think cultural psychiatry allows us to really focus in on that.